Assalamu alaikum. Hello, everyone, and welcome to today's session on patterned hair loss known as androgenetic alopecia. Thank you for taking time out and being here today. I am May Baraka, and I'll be moderating this session. I would like to introduce our presenter, Professor Ghada bin Saif, a professor and consultant of dermatology and hair disorders. Welcome, Professor.
أهلا وسهلا فيكم. Good evening, everyone, and I'm glad that we have so many attendees to listen to the patterned hair loss during the night time. And I wish that we could answer most of your questions. We'll keep the lecture for about half of the time, and half of the time will be for your to answer your questions. Okay?
Great. So, before we talk about this hair disorder, would you tell us more about the normal hair growth cycle, doctor?
Yeah, sure. The over the scalp and all over the hair, the hair and hair follicle is a regenerating organ. So it grow up and then it fall, and then it grow up and it fall. The factory is the hair follicle. Okay, the factory is the hair follicle, and it produce the hair shaft. So what we see is the hair shaft. The hair shaft go through three main phases: anagen, catagen, and then telogen. Anagen, this is the growing phase. Okay, this is the phase that grow up, and it usually the length of the growth is between 2 to 6 years. The importance of this duration, that this duration is the feature that determine the length of the hair. So the length of the hair is a genetically determined feature. People whose duration of the anagen is 2 years, that means their hair will be around 24 centimeters. Those whose duration of anagen phase is longer, this means their hair will be longer, okay? And it's worth to know, and it's an important feature also for us to know what is the normal. What is the normal hair growth rate? The hair growth rate of the scalp, it's around 1 centimeter every month. Okay, so it's so important that you know. So if you know the normal, when the patient complains that their hair don't grow fast or their hair is not growing well, you can refer back to the normal range. So the anagen phase, this is the most important phase. It's a duration 2 to 6 years, and most of the hair, around 90% to 85% of the scalp hair is in the anagen phase. What is the importance of this? If there is a disease or a problem affect the anagen phase, it will affect most of the hair scalp. As for example, in case of chemotherapy, the chemotherapy that causes anagen effluvium, when it affects the hair, it affects the anagen phase. That's why people who are taking chemotherapy, you can see them within like 2 or 3 weeks devoid of hair, no hair at all. Why? Because majority of the scalp hair is in the anagen phase. So anything that would affect the anagen phase, it will cause an extensive hair problem. Okay? And then the hair will get into the second phase, which is the catagen. The catagen, it's a very small phase. It's around 1 to 2 weeks. And also around 1 to 2% of the scalp is within this phase, the catagen phase. And then the hair will go to the third phase, which is the telogen phase. The telogen phase, this is the resting phase. And after this, the hair will be exogen. It will fall out. Most of the duration of the telogen phase is between 2 to 3 months. So that's why if there is a problem that would affect telogen, it usually takes 2 to 3 to 4 months until we can see the hair is falling. For example, a lady with telogen effluvium, postpartum, one of the causes of telogen effluvium is postpartum or post-surgical procedure. If a lady gets delivered, do we expect the hair shedding will start next day? No, it usually takes 2 to 4 months. Why? Because it causes telogen effluvium. The telogen will be falling. You need 2 to 3 months until we reach the telogen phase. Okay. the percentage of the hair that is in the telogen phase, it's around 10% of the hair follicle within the telogen phase. Okay. All the hair on the scalp are terminal thick hair. One of the problems that could affect the scalp, which we will talk about it in this disease today with the pattern hair loss, is that the thick terminal hair under the effect of hormone and gene could be miniaturized and become a villus-like hair. And this is what could happen in case of the pattern hair loss. Okay, so this is in summary the most important points and facts in the hair cycle.
So this takes us to our disease today, which is the patterned hair loss. So, doctor, can you define it briefly for us, please?
The pattern hair loss, this is the most common kind of hair loss. Okay, in men, around 95% of women suffer from pattern hair loss. Among women, around 25 to 35% of the women. It's a disease that present with a miniaturization of the hair follicle with a certain pattern. Why we call it pattern? Because there are patterns in this disease. There is the male pattern hair loss and there is the female pattern hair loss. So it affects men in a certain pattern that is different from the women.
So,
and it's a completely benign disease. It's a completely benign disease, but the problem with it that the prevalence is very high, and so it could affect the patient cosmetically and socially.
So is it commonly seen in your daily practice here in Saudi Arabia?
It's very common. It's very common. This is the most common worldwide hair loss. In men, as I told you, around 95% of the men suffer from it, but not at the early age, at later age. And women also between 25 to 35%. The general percent that men, around 50% of the men at the age of 50 suffer from male pattern hair loss, and 80% of the men at the age of 50, at the age of 80, suffer from pattern hair loss. Also, lady, it could affect people from the age of 12 years and as they grow up. As the people grow up, the presentation and the sign of genital alopecia or the pattern hair loss could be more evident. So yes, it's very common, not only in our clinical practice, also in the common population. It's very common that we see people who are suffering from male and female pattern hair loss.
So who are more susceptible to get AGA?
There are two main causes for the AGA. The people who are most commonly susceptible are the people who has a family history of pattern hair loss. Okay, but you should know that there are two main causes for the pattern hair loss, which is number one, genetic, and there are certain gene locus involved with the pattern hair loss. And the inheritance there are so many talk about it, but the most believed one is that it's a polygenic form of inheritance. This is one. The other thing is hormonal. It's hormonal and there are so many factors involved in it, whether it's in the cause or in. So generally speaking, who's mostly involved or mostly at risk is the person who has a family history of female or male pattern hair loss, and the inheritance could be from both sides, the mother as well as the father.
Okay. So can you tell us more about the pathogenesis and the relation of testosterone and dihydrotestosterone to this disease?
Right. I just, before I speak about this, I would just want you to recognize a few things about the hair loss. Most of the patients in the clinic, they would say, we are having hair loss. أنا أشكي من تساقط شعر. This is the commonest word, تساقط شعر. But not every patient who has hair loss has hair shedding. Okay, so most of the hair loss that people would suffer from, either hair shedding, that means the hair is falling, as in case of pterygium effluvium, like ladies who are brushing their hair, they see so much hair coming on the ground, so much hair in the brush. While they are taking shower, the hair is falling. So this is the presentation in case of hair shedding, which is one of the feature of pterygium effluvium. This is one. The other thing could be hair breakage, that the hair is falling, but it doesn't fall from the root. It gets broken, as in case of bad hair treatment, people who are using hair relaxer, hair straightener. Those people, they have hair fall, but it doesn't come from the root. It's hair breakage. The hair is broken. Both of those are not the case of the pattern hair loss. Pattern hair loss, what happened is the number 3, which is the hair gets miniaturized under the effect of the dihydrotestosterone, under the effect of the androgen. The hair follicle has many changes. Okay, what are the changes? The changes is, number 1, the hair follicle gradually with each cycle, it becomes small. And when the hair follicle becoming small, the hair shaft, because the hair follicle is the factory, as we said, isn't it? So the hair shaft that will come from the factory will be also small. So instead of having the hair that is thick, terminal pigmented hair, what happened with each cycle is that the hair becoming shorter, finer, the pigmentation is less. Okay? So this is what we call it miniaturized hair. Miniaturized hair. When you have a miniaturized hair, do you expect that it would cover the scalp well, or the thick terminal scalp? Even if you have the same number, which one expected to cover the scalp well? The miniaturized or the thick terminal?
The thick terminal for sure.
Good. Okay. So this is one of the things that happen, that the hair becomes small. The other thing, that with each cycle, the anagen phase becomes shorter. Okay. So when the anagen phase becomes shorter, that means it will not be longer. So the hair will get after that into the telogen phase quicker. So one of the other change, that the anagen phase will be shorter. So even the hair is becoming different in case of pigmentation, being fine. Also, its length will be shorter. Also, the percentage of telogen phase will be will increase more than the patient before he had the male pattern hair loss. Okay, so all these changes give us that the hair is thin. So the main problem in case of male pattern hair loss and female pattern hair loss is the hair thinning, not hair shedding, not hair breakage. It's a hair thinning. Okay. So what causes all these changes is the androgen. The testosterone, it gets converted into the hydrotestosterone, the active form of the hydrotestosterone. What converted is an enzyme. It's an enzyme called 5-alpha reductase. 5-alpha reductase, it acts to convert the androgen from testosterone to dihydrotestosterone to the active form, so it will make all these changes. So that's why among the treatment option that we are using is the 5-alpha reductase inhibitor. When we inhibit the function of the 5-alpha reductase at the level of the tissue, we will have less active form of the dihydrotestosterone, so we will have less action of androgen on the hair.
Okay, that's clear. So now going to the clinical presentation, what's the clinical findings that are characteristic of pattern hair loss in males?
Okay, right. It's very important, as I said, we need to differentiate in this disease between the male and the female, because the pattern in the male is different from the female. Okay, so in summary, they have the frontal hairline will be receded. That's why you can see some people when you go to the supermarket or they would seem to be a bigger forehead. So the frontal hairline receded, it come back gradually, and there will be frontoparietal recession. There will be recession on both sides at the frontoparietal area, so you can see what look like M shape. And then later on, there will be vertex thinning over the vertex of the scalp. This thinning, it usually in male, they start with the frontal hair recession, and then frontal parietal recession, and then the vertex thinning will start, and then with the progression, there will be merging of the frontal parietal area with the vertex. So that's why you can see that the fully balded scalp. This can happen in men only. Women never reach the bald side. The pattern in the women are different.
Mm. Before talking about females, can we have a simplified classification for assessing the severity of male pattern hair loss?
Yeah, there are many classifications, but the first and the most common classification is the Norwood-Hamilton classification. This is the first one. As you can see here, in class 1, 2, and 3, all what you can see is the frontal hairline receding. And then with the more advanced one, in case of 4 and 5, they start to have the vertex. You can see it, the vertex. And then the last stages, they start to have the merge between the frontal balding as well as the vertex. So using a Norwood-Hamilton classification, it's very important in clinical practice. In every visit, we have to document what is the classification, because this is the only tool and the simplest tool that guide us with the progression of the disease. Is the patient improving or not?
Mhm. That's clear. So now moving to females, what are the clinical findings characteristic of AGA among females?
Okay, in female, it's only hair thinning over the crown, but the degree of the hair thinning, it varies. Okay, so does a woman, now I'm talking about most, okay? Most women, how is the frontal hairline? Is it preserved or no? No, yes, it is preserved. In women, most of the time, the frontal hairline is preserved, but the main problem is the thinning of the crown. And there is very characteristic pattern in women. It's called Christmas tree distribution. So you can see the hair look like a Christmas tree thinning. This is, and again, even in women, we have a classification, but the classification in women, the that we are using in women are different from the men. In women, we use the Ludwig classification, which is, as we said here, 1, 2, and 3, and it varies according to the thinning of the hair. Can a woman reach to baldness? No. So this is one of the things that women frequently get afraid of. A lady would come to my practice. My father gets bald. My brother gets bald. I'm afraid to get bald. No, we always assure them. Most women, they don't get bald. But there's one thing it's worth mentioning. Can a woman have a male pattern hair loss? Yes, it can, but it's very unusual. Can a male have a female pattern hair loss? Yes, he can, but it's very unusual. Okay. The women, when they have male pattern hair loss, they usually have it post-menopausal. Okay, not earlier.
Mhm. Okay. So now moving to the diagnosis, what are the role of labs and biopsy in the diagnosis of pattern hair loss?
Most of the diagnosis of pattern hair loss, most of the time we diagnose them clinically because they are very easy to be diagnosed. They are very easy to be diagnosed. The pattern is very clear. And as I told you, we need to do some tests first clinically to differentiate. We need to always do hair pull test. We take around 60 hair, we pull them, and we see, does the hair come in our hand or no? If you have, for example, 5 hair and more falling in your hand, this means this is a positive hair pull test. Positive hair pull test is not a feature of a female pattern hair loss. It's a feature of pterygium effluvium. So one of the things always you need to keep it in mind is that pattern hair loss is very common. So it is not very uncommon to have two problems at the same time. Sometimes the patient presents to you with a female pattern hair loss, but she has also pterygium effluvium. Most of the ladies who present to us with pterygium effluvium, when we examine them, we find that they have also a female pattern hair loss. But when it was at the early or stage 1, Patient wasn't aware of it, but when she had two problems together, the hair loss become very evident. So always in assessing, almost always we need to do a good clinical examination to diagnose female pattern hair loss and male pattern hair loss, and also to rule out other cause of hair loss. Okay. Number two, so as we said, the hair pull test, doing hair parting, we do hair parting, and we compare the width of the parting at the frontal area with the width of the parting at the occipital area. It should be the same. If the width of the parting at the frontal area is wider than the occipit, this means the hair thinning over the crown is more. So this goes with the pattern hair loss. Okay. Also, as we said, doing dermoscopy is also important, as we said, because in dermoscopy, we find more of a mineralization of the hair follicle. We see that the hair is of a variable diameter, as you can see here in the photo. You have a very variable diameter of the hair follicle, and also we assess the terminal to vellus hair ratio. But um, diagnosing a male pattern hair loss and female pattern hair loss is very easy. One of the other things that we need to do during diagnosis is to rule out other systemic disease, because we said that the causes of the pattern hair loss has two main causes: genes as well as hormones, isn't it? So we need in every patient, particularly women, is to inquire about any other hormonal and or androgen excess. We need to inquire about whether she has regular menses or no, if she has hirsutism, if she has difficulty in getting pregnancy, if she is obese, if she has acne. If a patient has any of these and the history is suggestive, we may need to do hormonal workup to rule out these diseases. At least we need to do the testosterone, the free and the total testosterone, as well as the DHAAS to rule out ovarian and adrenal systemic involvement with the hair loss. Okay. Do we need to do biopsy? We rarely need to do biopsy. We rarely need because most, as I said, it is possible, but most of the time we can diagnose it easily clinically.
Great. So now moving to the treatment. What are the treatment options for pattern hair loss?
The commonest is the topical treatment. We frequently use topical minoxidil, and I'll talk about it orally because most of you, whether you are an intern or student, you will encounter it so much in your practice. We usually use topical minoxidil. We have two available forms. We have 2% and we have 5%. And the 5% has two forms. It could be solution or the foam. Okay? 5% is more potent than 2%. This is a fact. When you think 5%, there is solution and there is the foam. The problem with the solution that it has a propyl glycol base. So a lot of patients who are using the 5% solution, it is cheaper, but the problem with it, it might cause scalp irritation. So they might have scale and itchiness. So the 5% foam is better. Until a year ago, the 5% was not approved for ladies, but a year ago it was approved by the US FDA. So the preferable way to use is to use the 5% foam. Okay. If we use it for women, we use it once daily. If we are using it for men, we use it twice daily. Okay. And what is the amount? If you will use the buff, the solution, use around from 6 to 10 buffs. If you will use the foam, use what's around half of the cover. Okay, fill it with the foam and apply it over the scalp. Apply it over the scalp, not the hair, on the scalp. And be careful that the minoxidil do not get into your forehead or your face, because one of the side effects of the minoxidil is that it can cause hypertrichosis. So this is a problem in ladies. So always we need to apply it, we need to rub it, and then you need to wash. The patient has to be to wash their hand, so then he will not by mistake or she will not by mistake touch their face, and then will end up with the side effect of hypertrichosis. Okay. Always when we use minoxidil, it needs 3 months to start to see improvement. So one of the very important things that we need to instruct the patient and to educate them that male pattern hair loss, this is a lifelong problem. We cannot cure it. We are trying to control it. So the treatment that we will give, it will be a lifelong treatment. And also to see improvement, you need months and years to see a very good improvement. So the patient has from the start to be aware of that because most of our patients, they use treatment for 1 month. They don't see good improvement. They will discontinue treatment. Okay, so good education it's very important. So as I said, one of the commonest topical treatment is the topical minoxidil. Other than that, topical finasteride can be used, but the evidence on it it's limited. There are so many adjuvant treatment we can use with it. We can use the shampoos that has growth factor like bromi and others. There are shampoos that has anti-androgen effect, like when you are using the ketoconazole shampoo. Ketoconazole shampoo, it has an anti-androgen effect. Always ketoconazole has an anti-androgen effect. So if a patient is having androgenic alopecia and has a dandruff, good. Treat him with minoxidil, with the ketoconazole shampoo, the natural shampoo. So it will treat his dandruff as well as it will give him the anti-androgen effect. There is also, you can see in many of the advertisements, a comb, which is the low light laser therapy. And it has different name, different company. The patient comb their hair for around 15 to 30 minutes on alternate day, and it has also a good effect on thickening the hair follicle and the hair shaft. So these are the things that can be used topically. Okay. Most of the patients who are in early cases, for example, Ludwig 1 or Hamilton 1, we would treat them with topical treatment. We need to give them enough time, 6 months to a year before we shift to other treatment. Okay? If they did not improve, then we shift to oral treatment. Or if the patient from the beginning, they are an advanced case, we start with the oral treatment. The oral treatment in women, it is different from men. In men, it is very limited because we can't use a treatment that has an anti-androgen on men. And on women, we can use that. So in the men, we can use oral finasteride, oral dutasteride, or we can use oral minoxidil. Okay, each one of them has their effect, but the most common one is the oral finasteride. The problem with oral finasteride that one of its side effects in men that it might affect spermatogenesis, it can cause loss of libido, and so many other similar side effects. So that's why we need to be we need to give it to the proper patient. Also, oral minoxidil can be given, but one of its side effects is that can cause generalized hypertrichosis. That's why women hate using it. So this is in men. In women, no, we can add hormonal therapy. We can use spironolactone. You know, spironolactone is a calcium-sparing diuretic, but it has an anti-androgen effect, and it has a good effect in case of female pattern hair loss. So we can use spironolactone in ladies with the female pattern hair loss, but we have to be cautious not to give it to a patient who has a renal insufficiency or a pregnant lady. Also the finasteride, dutasteride, all these are not permitted to be used in lady. Why? Because they have a teratogenic effect. So finasteride is not only the woman should not take it, the woman also should not handle the tablet, okay, if she is pregnant or planning to get pregnant. So the issue with the finasteride, dutasteride, spironolactone in a lady is the teratogenicity is an issue. So the lady need to discontinue the treatment and to plan the treatment with the doctor very well with a good family counseling. Lady also can be given other treatment, like, for example, the sorbitolone acetate. Yeah. So if, for example, there is a lady, she has a mild kind of female pattern hair loss, we can give her minoxidil and we can discuss with her what kind of, she's using contraceptive pills, what kind of contraceptive pills. We can change her contraceptive to, for example, use the Diane 35 because it has a proterone acetate. And in this case, we have 2-in-1. She will do her contraception as well as this will help her her Um, so this is, in short, the most common treatment used in male and female pattern hair loss.
Okay, doctor, but before we continue, the voice is not so clear. Can you just bring the mic
Okay.
closer to your mouth, please?
Yeah. One of the things that is very important for you to know that the pattern hair loss, one of the good treatments for it is the hair transplant.
Mm.
And the hair transplant, we don't do it in very early cases, and we don't do it in also very advanced. Because the very early cases, they are very amenable to be treated by topical and systemic treatment. And if you use it in very advanced, we will not have enough area for hair graft. So always we do the hair transplant in, for example, Ludwig 2, for example, if it's a woman, and also in men, as I said, in the classic in the, for example, Hamilton 3 or Hamilton 4. These are good uh, for hair transplants.
Okay. Uh, Doctor, what are the about the novel treatments? We hear a lot about PRP, exosomes, Regenera for hair generation. So can you tell us more about these new treatments?
Okay, so until now, they are not considered among the protocol to treat the pattern hair loss. These are all new treatments. There are good study on some of them. The one that has the longest duration of use is a PRP. And PRP also there are two types. There is the platelet poor PRP, and there is the platelet rich PRP like the Magellan. So the platelet-rich plasma, the idea behind it that we are using it because of the platelet-rich plasma, because the platelet used to have a growth factor with it. So we are using it mainly for the growth factor, as well as that while we are giving it, there is an injection. So there will be like a manual stimulation of the scalp. Okay. There is a good result and a recent good publication on the effect of platelet-rich plasma on the pattern hair loss. But is the platelet rich better than the platelet poor? Is there any clinical study or a paper done on that? No. Theoretically, we think that the platelet rich is better, but there is no evidence. This is one. Regenera, they are using it for the stem cell. It's the same, but the difference, the platelet rich plasma, we extract blood. And then it's set in a centrifuge and then in a certain tube, and then we get the plasma. In Regenera, no, we take a skin biopsy from the scalp, and then they put it in the certain machine. The idea behind it that they plan to get the stem cell. Is it better than the platelet-rich plasma or no? We don't know. There is no clinical evidence that compare both or found that this is really effective. Exosome, it's a very promising, but there is an issue with exosome, which is ethical. Until now, it's not. Until now, the Saudi FDA, all the product for the exosome approved for topical use, not for injection. There is some ethical issue on the exosome, well, from where it's given, because one of the theories that if we are using it, it's a stem cell. Stem cell should work, but could it also lead to a certain disease, like for example, growth of cancers, or no? We don't know. So the exosome is still it needs to be on the safe side. It needs a little bit more data.
Mm. Great. So, is there any common misconception about the patterned hair loss you encounter in your clinical practice?
Yes. One of the fear of the patient, people they frequently fear that when you give them, for example, minoxidil, they say we don't want to take this medication because once we stop it, the hair will fall. This is the question that most of our patients would ask about it. Yes, this is right. If they stop it, it will fall because this disease is related to genetic factor and hormone. We cannot change your genes and hormone. But we always tell them to treat it and to stop is better than not to treat it at all. Because if you don't treat it with each hair cycle, and we mentioned that with each hair cycle, the hair will be shorter, will be thinner, isn't it? So it's better for any patient to postpone this effect, even if she use it, if she use minoxidil and then stop and then use and stop, better than not use it at all. So this is one of the thing. The uh, The other
So,
thing, as I mentioned before, the fear of baldness among women. Most of the ladies would ask, "Are we going to get bald?" We need to reassure them that it should not be bald. Is it a must that if a lady has a baldness, all her children will be or girls will be having a female pattern hair loss? No. This is also one of the common questions that people used to ask. No, it's a polygenic. Your daughter might have it or might not. Definitely your daughter have higher risk than the general population if their parents is having it, but we cannot be sure that all your kids will be having the female pattern hair loss.
so before we go to the questions, is there any advice or tip you would like to add from your clinical experience and practice?
Um, See, this is a lifelong problem. It's not like eczema that, or like an skin infection that you will give an antibiotic for 2 weeks and then the patient will be cured. So always when you are treating a disease that needs years of treatment, you need a very good counseling because continuity of treatment is better than giving a strong or better medication and then the patient will discontinue it. So always you need to plan the treatment with the patient, what they prefer, what they don't prefer. As I told you, I always with giving the patient I always give enough time for patient for instruction. If, for example, we will be giving spironolactone, spironolactone is a diuretic. When you set the dose, is it better that the patient will take it in the night or in the morning? No, in the morning. Why? Because if they take it in the night, the lady will wake up in the night because of it's a diuretic. She needs to go to the bathroom. So pay attention of this detail because patient may not pay attention to it, but it will affect their quality of life. Even when you are using the when you will give them the solution or the foam, discuss with them. This is the advantage of the solution. It is cheaper. It is available everywhere. The foam, no, it is more expensive. So some patients they don't mind having scale because they cannot afford the cost of the foam because as I said, the solution it's around a quarter or one third of the price of the foam. So I think good counseling is on those patients. So this is one of the things that I would give you an advice in case of male pattern hair loss is good counseling. It's a lifelong problem. The patient should use a treatment, and you will need every now and then to change the treatment. If if a lady came to you while she was 20, uh, not yet married, you have a variety of treatment. If she gets married and she wants to get pregnant, yeah, so many treatment you cannot give it to her because it will be risky, and so on. So the treatment plan has to be changed every now and then according to the patient situation and the disease severity.
Great. So moving to the questions, uh, we have a question saying, what's the difference between androgenic alopecia and male pattern hair loss?
Androgenetic alopecia, this is the old name. The old name, it used to be called androgenetic alopecia, but the new name, it's called patterned hair loss. And there is the male pattern hair loss and the female pattern hair loss.
Okay, clear. So other question says, how many months should we use ketoconazole in men to avoid the gynecomastia?
We don't give ketoconazole systemic in case of male pattern hair loss. We give the ketoconazole shampoo. As I said, because ketoconazole shampoo, it can use dandruff, and it has also an anti-androgen effect. So ketoconazole shampoo don't cause gynecomastia. So what I was mentioning, ketoconazole shampoo is not a standard treatment of male pattern hair loss, but I'm saying try to use all the options that you have that will help the patient. So if a patient is having dandruff, instead that you give him a shampoo that has a selenium, give him a shampoo that has a ketoconazole because it will do both. It will treat his dandruff as well as it will help his pattern hair loss.
So the other question is asking, is there any difference regarding the efficacy between oral and topical minoxidil?
Yes, sure, there is differences, but also the profile of the side effect is also different. Uh, um, there is no study that compare the efficacy of both. Also, the oral minoxidil, the efficacy depends on the dose. As you increase the dose, the efficacy will be better, but there will be a risk of having, because minoxidil orally, in the past, it's a treatment of hypotension, of hypertension. So when we give the oral treatment, always we need to give a very low doses. And if the patient is having risk, if the patient is having heart disease, there are certain contraindication not to give certain medication.
Okay, does minoxidil have a systemic absorption, a percentage?
Um, it's the absorption of 5% is more than the 2%. Uh, but the, that's why even if a lady, for example, is planning to get pregnant, you should not use oral or topical treatment, even if it's 2%. So yes, theoretically there is the 5% is more than the 2%.
Mhm. So the last question is, adding hormonal therapy to the oral minoxidil and oral finasteride will increase the efficacy? Will it increase the efficacy?
Can you say it again? I couldn't hear it.
Adding the hormonal therapy to the oral and oral finasteride and oral minoxidil, will it increase the efficacy?
Uh, See, we go for combination treatment in certain cases. Definitely, combination treatment will increase the efficacy, but sometimes you cannot mix any hormonal with any 5-alpha reductase inhibitor. So this thing, it's always it has to be according to the patient. Is he's a man or a woman? Is she planning to get pregnant and so on? And even the duration when she's planning to get pregnant.
So one more question is there any methods to increase the efficacy of topical minoxidil?
Yes, there is. This study found that if a patient is using the derma pen or derm roller, using the derm pen or derm roller before applying minoxidil, it can create channel, so the scalp and the skin would absorb more of the minoxidil. And there is a study on that, but the problem it's not very practical. Even if patient who has contraindication, sometimes we face it in the clinical practice, patient that has contraindication to use most of the systemic treatment. Okay, so even if you instruct them to use the derma pen, people don't have time to spend like half an hour every day to do the using the derm pen or derm roller before applying the minoxidil.
Mhm. So those were our questions. By this, we reached the end of this webinar. Thank you so much, Professor, for this valuable and fruitful session. I'd like also to thank you all for your attendance, and I wish you all a very good evening. Thank you all.
You're welcome. Hope you enjoy it and hope you find some benefit with it.